here at Dana-Farber Cancer Institute, we're blessed by having a database that uses molecular data, cytogenetic data, path data, and clinical data to allow us to ask retrospective questions about various malignancies, including AML. And Dr. Shimoni, who led the study, and I supervised him, looked back at our older adult patient population, which was several hundred patients over the past roughly 10 years, to ask some questions, one of which was, does FLT3-ITD carry an adverse prognosis in the older age group of patients with AML? Because we've known for years that patients with younger adults with AML, at least in the pre-FLT3 inhibitor era, who had a FLT3-ITD, did not do very well, had a high relapse rate and a poor overall survival. That may be improving of late with the use of FLT3 inhibitors in the early treatment of patients along with chemotherapy. But the data with older adults is less clear. Midostaurin is approved for older adults who are fit for chemo, but there's no approved regimens other than azacitidine venetoclax for chemo unfit patients with FLT3 AML who were previously untreated. So we asked the question about what the prognosis is compared to FLT3 wild-type patients and FLT3-ITD patients, and found no difference. I think that was due to in older adults, defined as people over age 60. I think the reason for that was multifold. One is that over the course of the analysis period, the last 10 years, there was a slightly increased use of FLT3 inhibitors in the older population. But there actually weren't that many patients who actually received them. I think another reason that the prognosis was no better is the presence of co-mutations, particularly those with adverse prognosis, such as the so-called secondary AML mutations, which are typically splicing factor or chromatin remodeling genes. So this certainly calls into question our previous notions that FLT3-ITD is an independently poor prognostic factor in AML. So we did not have that many patients who received specific therapies such as FLT3 inhibitors or transplant to really make strong comments about how patients should be treated. But it certainly does call into question our notion of poor prognosis of FLT3-ITD in the older population.